Diabetes, we all know, is a major risk factor for development of cardiovascular disease. Some people may not consider it as a cardiovascular risk equivalent, but their cardiovascular diseases increases up to 2 to 4 times in patients who are having diabetes. So we need to have some strategies in by which way we can prevent these cardiovascular diseases in patients with diabetes. And there are multiple trials which have been done on various aspects, various pathways, targeting the various pathways which leads to the cardiovascular disease, including the lifestyle interventions, using statins for controlling dyslipidemia, using antihypertensives. So all these factors are already in use, and one of the pathway which we want to target is the platelet activation in diabetes patients. So in diabetes patients, especially, the platelets get hyperreactive. So we need some targeted therapy which can actually act upon this and which might prevent the development of cardiovascular disease, and that's why there is a role of aspirin in the prevention of cardiovascular diseases. Well, there is no doubt that aspirin is recommended and it is beneficial in those patients with diabetes who already have a cardiovascular event, like who are already have suffered an MI or a stroke or any peripheral vascular disease. In those patients, aspirin has a proven benefit. This is called secondary prevention. There is no doubt about it. However, the controversy is the primary prevention. So the controversy is whether using aspirin before development of any vascular event, can it prevent or can it prevent the development of these cardiovascular events. So the role of aspirin in primary prevention, the trials on this with the use of aspirin as a primary prevention started in late 1980s. So initially those trials were focused mainly on the general population. The diabetes population was not included, and those results did not show any significant benefit, which led to FDA to say that aspirin is not recommended for primary prevention in 1970s as well as late 1980s as well. However, in late 2000s, the studies on diabetes population started appearing. The two big studies were, one was done in the Japanese population, and there was another study, an ETRDS study also. So these studies in late 2000s were done mainly in the diabetes population for the prevention, for use of aspirin as a primary prevention. And what these studies revealed, that there was non-significant reduction in the cardiovascular events, and hence again FDA stood by its point of view that aspirin is not recommended as a primary prevention. However, the downside of these trials were that these studies were underpowered, and because the cardiovascular events which were anticipated were quite high, but then actually what happened were quite low. These studies were underpowered, and 10 years later now came this study called ASCEND study, which was published in 2018 in NEJM, which was actually done in a very targeting mainly the diabetes population. It has been till now, it has been the largest study for the use of, to show the use of aspirin as a primary prevention in the diabetes population. It included around 15,000 patients, and it randomized, well, for these 15,000 patients with diabetes were randomized to receive equally to receive either aspirin 100 milligram daily or placebo, and then these patients were followed up for a mean period of around 7.4 years. And the primary outcome was basically the composite of the serious vascular event, which was a composite of MI, stroke, TIA, or any vascular death. So what was found after following up these patients and after 7.4 years, that patients who were taking aspirin, the events occurred in 8%, whereas patients who were taking placebo, the events were on the higher side, 9%. So that means there was the relative risk was 8.88. That means it led to 12% reduction. Use of aspirin in diabetes population led to 12% reduction in the development of first serious vascular event. Now this was a composite outcome. However, when the individual outcomes were looked into, there was no significant difference. However, still this led to modest beneficial effect. Now if you look at the benefits, then there were another biggest trials which were done with the use of aspirin as a primary prevention the same year, the ASPRI and the ARRIVE trial. The ASPRI trial, which was done mainly in the elderly, also included around 11% of diabetes population, whereas the ARRIVE trial was excluded diabetes population, and these two trials actually did not show any benefit with the use of aspirin in the primary prevention. So updated meta-analysis which was done in 2019, which included the ASCEND and the ASPRE trial, also showed that if you look at the overall vascular mortality, there was no significant benefit with the use of aspirin as a primary prevention. But if you look at the MACE as the main outcome, then aspirin did show some improvement, some reduction, which is in the tune of 9%. So modest but significant reduction in the MACE outcome in this meta-analysis. Now this has been the benefit of use of aspirin in primary prevention till now. Now what are the risks? The risk is mainly the bleeding risk, and what was seen in the ASCEND trial that this major bleeding risk increased by 29%, and the main bleeding site was the GI tract and the upper GI tract. However, there was no significant difference in the terms of the fatal bleeds or intracranial hemorrhage if you compare the aspirin and the placebo group. So, and also subsequently the meta-analysis which was done including this ASCEND trial for the look at the safety outcome, it was shown that in the diabetes population there is significant increase in the major bleed with the use of aspirin, predominantly the GI bleed, but there is no significant increase in the intracranial hemorrhage, which is in contrast to the meta-analysis which included both diabetes as well as non-diabetes population, which showed that there was the risk of bleeding was even there of intracranial hemorrhage as well. So looking at this benefit and as well as risk, how do we reconcile the results? How do we balance it out? So actually it's very difficult. It's the biggest challenge, whether we can weigh both the events, a bleeding event and an ischemic event, equally or not. We don't know what will be the long-term consequences of these two events. So the number needed to treat in ASCEND trial was 91, whereas the number needed to harm was 112. There is a fine balance between the benefit and the risk. The benefit was not much, but the bleeding risk was much higher. This is as opposed to in secondary prevention trials with aspirin, which has clearly shown that benefit extends much beyond the bleeding risk, and therefore the ratio is much superior for the benefits. Now, what could be the reason that we are not getting the good benefit with the use of aspirin in the primary prevention? One of the reasons is that now since the availability of statins and the improvement in the lifestyle factors, that already the risk factors which cause the cardiovascular disease are well controlled. So even in the ASCEND trial, the population was low to moderate risk. It was not a high risk population. So maybe all the factors are already taken care of with the use of statins, smoking cessation, blood pressure control, other lifestyle measure. If you add aspirin on top of that, it will not lead to much benefit. Other speculation is that in many of these trials, the adherence rate was very much less with aspirin. So we don't know whether it clearly led to the benefit or not. There is a possibility of aspirin resistance in diabetes patients, that aspirin may be not acting properly with such dosages. However, in ASCEND trial, it was clearly shown that there was no significant difference in terms of the, it has been also been speculated that in obese patients, aspirin dose might be required as higher. However, in the ASCEND trial, it was shown that outcome was same even in the obese or the normal weight patients. Now, the other possibility is that in these trials are not selecting very high risk population on the basis of the modern CAC score. And also we cannot say how much patients were using NSAIDs and alcohol, which had increased the bleeding risk. So many confounders and could be there which can say that bleeding risk is high and moderate efficacy is less. So what are the recommendations? As per now, the two major recommendations which we follow for patient diabetes, the European guidelines and the ADA guidelines. So what European guidelines say is that you can use aspirin for primary prevention only in the high risk or a very high risk population. So how it defined high risk population is that those patients who have either a target organ damage in the form of a kidney proteinuria or a kidney damage or an LV dysfunction or a retinopathy, or patients who are having 3 or more major risk factors in the form of obesity, hypertension, dyslipidemia, smoking, or a premature family history of premature cardiovascular disease. So these patients are defined as having a very high risk or high risk population where aspirin can be used for the primary prevention. However, it does not advise to use aspirin in the low risk population such as age less than 50 years or who are not having any other risk factors. Similarly, ADA recommends to use aspirin in patients with more than 50 years of age who have one or more major risk factors in the form of, again, hypertension, dyslipidemia, obesity, smoking, or a family history of premature atherosclerotic cardiovascular disease. But the main common thing which both the recommendations say is that you need to rule out a high bleeding risk in a patient. These patients are, we need to screen such patients who are at a high bleeding risk, such as older age, who have anemia, who have thrombocytopenia, history of a GI bleed or a history of a GI ulcers. So these are the patients in whom the aspirin should not be prescribed. So it still remains a controversial issue, or more or less it is very clear that aspirin should not be used routinely in patient with diabetes. It's not like diabetes patient is coming to you and you're writing an aspirin. That is completely out. It's better emphasis should be given to the risk control of other risk factors in the form of optimal use of statins, optimal use of antihypertensives, lifestyle measures, smoking cessation, which can actually abate most of the cardiovascular risk in these patients. And so aspirin use might be restricted to certain high risk population, and identifying this high risk population could be a challenge. So one way is high risk you can call when these patients have one extreme risk factor in the form of, if it's heavy smoker, the patient has premature family history, premature atherosclerotic cardiovascular disease, or if the patient has uncontrolled lipids, blood pressure despite on the drugs. So these are the candidates who will benefit from the use of aspirin therapy. Or maybe the use of CAC score can identify these high risk patients. So the CAC score is more than 100, these patients can benefit from aspirin therapy. Whenever aspirin therapy is to be used in primary prevention, it should be used in the lowest possible dose in the form of 75 to 100 milligram. Underlying bleeding risk should be ruled out, and also these patients, patient discussion is very important. What patient wants, what patient prefers, whether patient prefers a bleeding event over ischemic event or a ischemic over a bleeding event, that becomes very important. So as of now, aspirin in the primary prevention threshold has become very high now to start for aspirin for a primary prevention of cardiovascular disease and diabetes. Thank you.